Discharge planning is an important part of the OT process. In acute care, occupational therapists play an important role in the team when providing the input in discharge planning. To the patient, it may seem like the doctor makes the call, and while ultimately they do make the final call in deciding when, if, and where a patient discharges to, the doctors often seek approval from the therapy team, including occupational therapists, before discharging patients. In the real world, discharge planning is not a straightforward process. And as a new practitioner, it can be overwhelming when there are many things to consider. So I compiled a list of the top 5 discharge planning mistakes to avoid to at least help you to get familiar with the OT discharging process. Of course, this is a general list, and each patient and their discharge plan is unique, but hopefully this can help you get started with thinking about and how to think about discharge planning, because often what we learn in school is different than what is in the real world. If you are new to this channel, I create occupational therapy content to uplift the profession and to spread awareness about the field of occupational therapy. Check out all of my resources in the video description. You can also help support this channel by subscribing and becoming a Patreon member. Number 5 on the list is not discharging from day number 1. You may have learned in OT school or in your fieldwork to discharge plan as early as possible, starting from day 1. However, many new practitioners may be hyper-focused on, say, completing an evaluation, and they may not consider discharge planning until it is too late. And I get it. An evaluation may have a lot of parts to it. Client's history, diagnosis, prior level of functioning, current functioning, assessment scores and interpretations you have to worry about, and so on and so on. In an ideal world, patients would get the most time that they deserve for occupational therapy, with all the resources they need and the staff too. But in the real world, especially in acute care, things move very quickly. Patients may discharge just like that in a few days, the next day, even the same day, depending on their condition. This is why discharge planning needs to happen on day 1, because if things start moving fast, you as an occupational therapist would have thought of the questions that the doctor, nurse, patient, family members, other therapists would approach you to ask. And it may seem like occupational therapy may be neglected or ignored in terms of like our input in discharge planning, but oftentimes doctors may even read your notes, or the nurses may as well, in consideration for discharge planning and how to make and when to make the decision. And this leads me to the number 4 mistake to avoid, and that's too much DME, or durable medical equipment, or too much adaptive equipment. And we may often get so caught up in the OT mindset that we overprescribe stuff. But in reality, will the patient really need it? Like, do they need that extra commode? Do they need those extra reacher grabbers? Did you even bother to ask the patient if they already have an obscure thing like a reacher grabber? Maybe they have it already. What will it cost the patient? Because more times than not, if Medicare or insurance will not pay for it, the patient will probably not have the finances, or is not willing to buy something that they do not see the value in. And more oftentimes than not, it comes down to not having the finances. I have kind of experience in terms of getting these kinds of things. And unfortunately here in America, most adaptive equipment is not covered, and DME is only partially or is completely not covered. A shower chair is a common one that is not covered by Medicare. So it's a balance between safety and function, and in what is need to have versus what's nice to have. And this is when you should use your critical thinking and about the patient and their big picture. For example, will the condition improve rapidly? That kind of thing. And it would not make sense for them to buy one. Maybe they can borrow one from a neighbor. Maybe they had a spouse with like a condition and they already have it and they bought one already. Maybe they forgot they had one, such as in storage. And this happens when you do an eval and they go, I don't know. Maybe you can have a family member check at home and see if they actually do have it. Or maybe they may not even need it altogether, and they can maybe get a lot of help and have, say, a caregiver stay with them for a few days and can get by without, say, a sock aid or a reacher grabber. Each case is different, but in general, overprescribing can add to a lot of the complexity, cost, and stress for the patient and family come discharge time. Having too much clutter may pose a risk in itself too, right? Such as being a fall risk. One trick that I learned is to refer back to the initial evaluation as the therapist, whether it is you or someone else has likely probably asked the questions about the equipment and things they have already. If you don't find what you need in the OT notes, refer to the PT notes. And if you don't find that there, then you can probably ask the patient or the family members. But looking at therapy notes in the evaluation can save you a lot of time for discharge planning. The number 3 mistake is not conferring with the team. This could be therapy like physical therapy and speech therapy, but also other disciplines that are on the team, such as nurses, technicians, dietitians, social workers, psychologists, case managers. Conferring with the team is important because it can give you, the occupational therapist, an idea of what other disciplines are thinking about and how the patient is actually doing with them in their specific discipline, and also to get an overall broader picture of how they're doing overall. It is also very helpful because if you are way off the mark, such as thinking of the patient can go home, but if like physical therapy, maybe thinking skilled nursing facility, then you can both discuss why each of you think that's the case. This can help the team come to a consensus easier and to reduce confusion, especially in team meetings, for the doctor to place the discharge order or not to. And I myself often make this mistake, as not conferring with therapies can be easier to do, as we often may be so focused on our list of patients and seeing them and doing our work and then documenting too, right, afterwards, that we may not prioritize checking with other disciplines to see how they are doing. And I'm not expecting you to confer with like every single discipline for every single patient that you have on your list, just with the disciplines you think that are relevant. For example, if an ambulation issue, then PT. With dysphagia or memory, then speech pathology. If a toiling issue or skin breakdown, maybe nursing, and so on. I make it a good rule of thumb for myself, at the very least, to debrief with nursing to tell them my discharge plan as of the most recent session. Communicating with the nurse and debriefing with them after your session is good practice anyways, but especially telling them your discharge plan gives them a good idea of what to communicate to the doctor or what to say during rounds for them, because oftentimes nursing may not have as good of an idea of how patients are functioning and doing, especially with therapies, because they have, nursing things to do. And doing this overall can help because they may be in bed even with, say, nursing when they're not getting up for therapies. The number 2 mistake is no family training, especially when the time comes close to discharge. Family training is important because you want patients to be successful at discharge and to be supported and to feel supported. Personally, for me, I prefer family training, like the family and the patient and me, instead of over just printing handouts or even just training the patient one-on-one. Having a family member trained can provide additional reinforcement for safety, function, and meaningful occupations, especially if the patient may have cognitive or psychosocial impairments. Family training is most appropriate for home discharges and not so much for transfers to other facilities such as skilled nursing or acute rehab. And this depends on the patient and their level of functioning too, and what you expect them to be, whether they are going to be alone or they will have help from caregivers. If they're going to be expected to discharge independent, then of course family training will not be necessary. But one thing I notice quite often is that in times when family training is and should be appropriate, it is often not completed, and it would have been a lot of help. While I get that scheduling of family training and for family to come requires a lot of coordinating and can be quite involved and requires a lot of effort, it is well worth the effort because it is in the patient's best interest and could potentially lead to improved outcomes and even potentially, I'm thinking, decrease hospital readmissions. The key is to plan ahead and to constantly remind the team, such as physical therapy or nursing, that you want to do some family training. You can even come together and do it with PT and do co-treats. The best cases are when the family is already there. I know with COVID-19, it's a little bit tougher, and you can train them kind of on the spot and you kind of kill 2 birds with 1 stone. This, of course, assumes that the family that is present are the ones that will be the caregivers and aren't, say, like a friend visiting from out of town or as a relative who is just visiting and is not going to be directly involved in their care. So what about in cases when there is too much family I'm sure you may have all experienced this, like an overly supportive family, and there's just too many people, kids running around, all that sort of thing. In these cases, it's generally best to designate one person as a point person who will be trained, or maybe two people, but probably no more than that, as this will definitely lead to more complications, anxiety, take up more time, and can be very distracting, especially for the patient. After, say, one family member is trained, if they're deemed competent as, a caregiver, then they can teach other people and family members afterward themselves. The sun's in my eye. I really need to get some blackout curtains. And the last number one mistake is basically not being client-centered for discharge planning. This involves not discussing or collaborating with the client or the family about their discharge plan. This mistake may often be made because it can be easy just to go off your clinical reasoning and your judgment, and it takes more effort to discuss with patients and their families what you want to do in terms of occupational therapy and the discharge plan. But patients may already have a discharge plan or destination in mind, how long it will take to get there, who they will be going with, and this may be different than what you as an occupational therapist or what your team wants. And it may even be different than what the patient was at baseline. And whether their idea of a discharge plan is realistic or not, it is a good idea to know so that you can be client-centered and provide the best therapy for the patient, even in a setting such as acute care. And it's not always safe to assume that where patients came from was where they want to or hope they will go come discharge time. Of course, when you consider a family, there can be some drama involved. While it's not necessarily your job to decide and to fix these kinds of things, you can involve a case manager in these cases and be like, hey, the patient is thinking this, but the family wants this, but therapy is actually thinking this, for example. And these kinds of discussions in acute care don't need to be like an assessment interview or anything like that. They can be simple questions such as, where are you hoping to go after this? When do you think you would be ready to go? Who will be your caregiver? Who will take you home? Have you considered any alternative options or plans? Are you hoping this to be temporary or for long term? That kind of thing. And also you might want to be careful with what you disclose or share with the patient in terms of their actual discharge plan. Sometimes the doctor may want to bring this up. Sometimes it may be more complicated and cause unnecessary stress. So it depends on a case-by-case basis and many other factors in terms of things, like costs, insurance, placement issues, opening at facilities, other medical complications or issues, outpatient issues. And these days, like COVID-19 can make things even more complicated. So don't overpromise, I guess is what I'm trying to say. So with these 5 discharge mistakes made in acute care, does it mean that if you make these mistakes that you're necessarily a bad therapist? Not at all. Each patient and their case is unique, and the same goes for their discharge plan. Often, given 2 patients who are the same age, gender, diagnosis, live in the same neighborhood even with the same caregiver assistance, each of their own discharge plans can even be completely different. Discharge planning may not even be possible from day one, such as a patient being on hold from therapy. DME may not even be relevant, such as a patient transferring to a skilled nursing facility. Conferring with the team may not be appropriate at the time, such as due to a lack of insurance and we don't even know where the patient may go. Or family training may not even make sense, as, for example, the patient may live alone and may be expected to discharge at independent level, for example. So not all of these are like hard and fast mistakes, but personally, I think that the one mistake overall that you should generally try to avoid is not being client-centered when it comes to discharge planning, as this shifts the goals towards the therapist or the team, like the medical team, rather than being collaborative with the patient. So I hope this helps. If you found this video helpful, give it a thumbs up so I know to make more of this kind of content. Thanks for watching. I'm Jeff the OT Dude, and have a nice day.